Now, these Centers for Disease Control has developed a surveillance program known as the National Nosocomial Infection Surveillance Risk Index. And this risk index looks at three major factors to classify a wound and to classify a surgical site infection. First, the factor of the wound class, is it 1 to 4? The procedure and how long the procedure lasted. So usually when one looks at procedures, that the higher the number of points, the longer the duration. The ASA class, which is from the Anesthesia Surgical Society, looks at the length of time and the rate of how long one has had a risk to an infection. So the higher the number, of course, the higher the risk for a surgical infection. The American Society of Anesthesiology has the ASA score, and this slide depicts what are the classifications, their definitions, and then the patient characteristics associated with those definitions. And the important concept here is that the higher the classification, the more at risk the patient, with general characteristics associated with underlying systemic disease processes with the patient. If one looks at a basic surgical site infection risk index and one has a high ASA score, one has to look at the duration of the surgery and then the wound class, and note that if it's a longer surgical procedure, such as an example being a cardiac bypass surgery, that these types of surgeries lasting 5 hours or greater have a higher rate of infection because of the length of the surgery and also their wound class. Though they may be clean at the outset, they may become contaminated, meaning during the surgical procedure, which can cause a surgical site infection. Other issues are, of course, in surgical site infection are the post-operative issues, meaning how is the incision being cared for and how is the patient being cared for when they return, when they leave the unit or they return to home. Now, how can we prevent surgical site infections? What do we know? What do we already know in the literature, and what do we know in terms of making sure that the incidence of SSIs do not go up? The first, of course, is good aseptic technique, and that's during the operative, pre-op, and operative phase, that the healthcare workers use good aseptic technique during the operative phase, and then post-op that the aseptic technique is continued in wound dressing changes. Second is antibiotic prophylaxis, that we know, and we have data that shows that when antibiotic prophylaxis is used at the right time and the dose given prior to surgery, that there is less rate in terms of surgical site infections. Third, changing gloves during the surgical procedure when contaminated has shown to we see that it decreases surgical site infection. When healthcare workers are aware that they contaminated and that they changed their gloves during the surgical event, then we know that we can decrease the rate of contamination, therefore decrease infection. Last is the use of double gloves, and there's been data in the literature that has demonstrated, especially in orthopedic surgery, that if one wears double gloves, that by using double gloves, that perforations from sharp objects and from instruments are less on the inner glove than on the outer glove. Second, there's some data in the literature to show that when healthcare workers know by an indicator system, meaning a different color of a glove, that when they know that they have perforated the glove, then they are more compliant to changing the glove quicker on the outside, which then decreases contamination. There is also data in the literature that demonstrates that glove liners or cloth gloves that are used in between double gloves can also decrease the rate of contamination because the skin is never touched from the patient to the healthcare worker by instruments or vice versa. Now, prophylactic antibiotics are very important. There's been several literature that shows that antibiotics that are given for the purpose of preventing infection When infection is not present, but the risk of postoperative infection is present, is very positive. In other words, if it's a wound classification of a 4, for example, a dirty contaminated wound, antibiotic use is very important because it would then prevent any precursor to an infection. In a class 1 wound, if one gives antibiotics prior, one knows that it also prevents any predicted surgical site infection. Some benefits of prophylactic antibiotic use has been demonstrated in several types of surgery. The first being GI procedures, including appendicitis. When antibiotics are given, SSIs decrease. Second is oropharyngeal procedures. Third is abdominal leg procedures that are vascular in nature. Open heart procedures has been very clear that when prophylaxis is given, there's a lesser rate of sternal wound infection. Obstetrical and gynecological procedures are other procedures that antibiotic prophylaxis seems to work. Orthopedic hardware replacement, any type of orthopedic surgery in which there's hip replacement or knee replacement and or rods have been shown to decrease the rate of surgical wound infection. Last is craniotomy, where we have seen that if using prophylactic antibiotics, that we have a decreased rate for the surgical wound in terms of an infection. Then on some clean procedures, we also see that there's a benefit, again, to antibiotic prophylaxis. First is orthopedic joint replacement. Second, open reduction and closed fractures. Vascular prosthesis, vascular procedures on the legs, median sternotomy, and craniotomy. Last is breast and hernia procedures. So there's data to support that when prophylactic antibiotic use is given and used 30 minutes prior to the surgical event, then we can decrease surgical site infections. Other data in the literature that's really important is now the use of double gloving to prevent surgical site infection. Double surgical gloves have been shown to protect against cross-infection by providing additional barriers between the healthcare worker and the patient. Second, double surgical gloves also reduce the risk of contamination during surgery merely by decreasing the rate of perforations. The American College of Surgeons has actually stated that double gloving will protect the patient better from surgical wound contamination by decreasing the likelihood of sweat spilling from inside the surgeon's gloved hands, especially on those procedures that are lengthy. The American Association of Operating Room Nurses have recommended that wearing 2 pairs of gloves may be indicated in certain procedures, but they did not make recommendations in terms of all the types of surgical events. Now, prevention of the surgical site infections and double gloves has been documented in the literature, and it has become common practice for most surgeons to use double gloves now in most of the surgeries. A study by Thomas Argwal and Mehta in 2001 demonstrated that 50% of outer gloves versus the inner were perforated, therefore made it very clear that skin contamination can be totally decreased or obliterated if surgeons wear double gloves. Others, such as Quebelman and Albin, have demonstrated that any time double gloves are used, inner gloves are less perforated than the outer gloves. Therefore, the recommendations are to wear double gloves versus single gloves. Others in the literature have documented that double gloves prevent cutaneous blood exposure and should be routine in surgery. And they've made these recommendations both in the literature and to various professional groups. The University of Virginia recently, in 2002, at their Center for Patient Safety and Healthcare Worker Safety, recommended that double gloves provided better barrier protection than a thicker single glove. And the reason that the center recommended that is because once the sharp object perforated the glove or went to the skin, then there was cross-contamination to patients. So some conclusions associated with double gloving and surgery is it's very clear in the literature that double gloves are recommended for routine surgery. Second, professional organizations, most of them make recommendations associated to double gloving, such as the American College of Surgeons and the American Association of Thoracic Surgeons. But it's interesting to note that they have not made a clinical standard associated with double gloving. They recommend as good clinical practice, but they don't say it's a standard to perform surgery. There are some infection control considerations for surveillance that's very important associated with gloving and also for surgical site infections. One is that we have to assess and be able to treat infections, and therefore we have to educate the care providers. We have to understand overuse of antibiotics, because to use prophylaxis is good, but to overuse the antibiotics isn't good, because then individuals become resistant. And last, we have to facilitate what's known as antibiogram programs, which means that those programs where we know specifically the organism that's causing the infection and treat routinely for that particular organism. For infection and control prevention, it's important then to make sure that surgical site infections have to be monitored and controlled. Why? Because we have an increased rate of cost, and that we know when one person gets a surgical site infection, we have a increased length of stay, which costs us around $3,152 extra for every person that has to stay longer in the hospital within a 7-day period. Also, we estimate that 40 to 60% of SSIs can be preventable with appropriate antibiotics and appropriate surveillance. Estimates that look at antibiotic overuse or underuse and misuse occur in 25 to 50% of surgeries. That's why it's important to monitor from the time the patient has to undergo a surgical procedure until the time the patient is recovered from the surgical event. Surveillance methods include not only inpatient surveillance, but post-discharge surveillance and outpatient surveillance, which means that when the patient goes back to the doctor after they're discharged from the hospital, that one needs to know whether or not they had a surgical site infection or not. So the intensity of surveillance is very important. The literature suggests that 30 to 50% of SSIs are detected by post-discharge, but varies, and that the procedure for higher and clean procedures are even more difficult to track when one's not doing surveillance, and that the postoperative length of stay is one of the ways to track for SSIs. Readmissions and the method of post-discharge data collection are just some of the ways to look at SSIs and to increase our infection control and our surveillance intensity. Post-discharge rates are important because NSI wants to know exactly how many individuals got a surgical site infection even after they were discharged from the hospital. Therefore, the monitoring of readmissions is practical, and some outpatient monitoring by doctors' offices and or surgical clinics are important. Controlling for postoperative length of stay has an effect on the analysis, but if one looks at the length of stay, we have a better rate in terms of surgical site infection. So continuous monitoring for surgical site infection is important. Therefore, early assessment of the surgical site, diligent management of postoperative patients, planning and communication, and use of methods for surveillance helps us to benchmark SSIs. Surveillance also can be global, and some of the global goals affect the prevention and control processes associated with public health. and public health makes decisions about how to do this surveillance. A lot of this is controlled by the CDC and has been recommended in terms of the incidence and prevalence of SSIs. Most of these are done by regional and then national and global reporting to the CDC. Global health includes both the biological and the economic policies of a monitoring system, and most of the global surveillance programs monitors any types of changes in human health to prevent. When we survey SSIs, for example, the CDC helps to improve health or prevention of the disease by the numbers of SSIs that are reported regionally, nationally, and then globally. And hopefully the surveillance helps to build the infrastructure for a prevention method for SSIs. The outcomes of care are very important in terms of designing and reducing the frequency of adverse events that are associated with SSIs, infection, or injury. And these surveillance programs helps us make better clinical decisions associated with SSIs. The Institute of Medicine has made some recommendations associated with the global network related to nosocomial infection rates and also SSIs. They have made recommendations that the U.S. take an active role in providing this information and providing a global network so that there can be collaborative health research associated with reduction in SSIs. And I want to thank you for this lecture.